When they continue to suffer, they mean more exacerbations, hospitalizations, poor quality of life, rapid decline of lung functions, and of course, higher mortality. It is estimated that about 5 to 10% of patients, despite the best of the therapy being given to them, which is ICS-LAVA combination, or add on to one or two drugs which are available, still continue to suffer as an uncontrolled asthma. But what is important here is that this is not actually the therapy-resistant asthma. Because everything which is uncontrolled asthma does not translate into therapy resistant, because there are many factors in between which needs to look into that what is causing the asthma to be uncontrolled. So this ERS ATS guideline of new definition of therapy resistant severe asthma actually tries to clarify and brings more clarity to what we are talking about when we talk about severe therapy resistant asthma versus uncontrolled asthma, where you know that the certain things needs to be satisfied before you label it as a severe asthma. What it means is the patient is on high dose inhaled corticosteroids plus long acting beta 2 agonists. Patient may require burst of corticosteroids and still remains either uncontrolled or is controlled in a way that the drugs are causing either serious adverse events, or what more could be that the patient is not tolerating the drugs. So such a situation in India, how bad or how good it is. Now this is a study which has been already showing that all asthmas are not severe asthmas and all severe asthmas are not uncontrolled asthmas. So at the end of the day, you may be having about 40 to 50% of severe asthmas being uncontrolled, which itself constitutes about 5 to 10%, and as per the study by Dr. Ghoshal and Rajadhar, it is about 9.8% in Indian population. Although it's not a very large study, but it gives us a view that perhaps we are looking at 10% of severe asthma in an Indian population. But another study, which is from Salve, and I think Randeep's name is also there, it has shown to look into what is about control in asthma. And this is absolutely shocking. Because what you look at it, that 91% of asthmatics in India feel their asthma is controlled, but when they are put into the rigorous measures of GINA asthma control, you find that the asthma control in Indian population of asthmatics is 0%. What does it mean? We are a poor perceivers? Maybe that's one of the answers. But what it would translate to is every uncontrolled asthma is not severe asthma in India. So it is to be seen that how do we reach this uncontrol into severe asthma and severe asthma to therapy resistant asthma, which requires certain steps. This has also been endorsed by GINA, and it says that not only you first confirm the diagnosis, but very importantly check the compliance, the technique, adherence, all the issues related to the therapy, including appropriateness as per GINA guidelines. So you should be, as per the GINA guidelines, being given the correct therapy, you must be using it, your technique should be correct, and when everything else comes down to that it is right, then you also see that if there are associated conditions or comorbidities, then they must also be addressed before reaching a stage where you start wondering that this is one variant of that asthma which requires perhaps out of the box or the newer therapies which we are looking at today. So that can be severe asthma controlled with high level drugs with serious side effects, or remains uncontrolled despite GINA step 4 and GINA step 5. Technique and compliance is very important. There can be adherence issues which can be intentional or pseudo-adherence, and of course compliance is something which is of real issue here. There are two studies for which I would like to quote here. One was SMART, that is the digital counter inhalers, which was a dust study which was presented in CHEST 2017, which did show that the digital counters as well as the right kind of a combination of PMDI with digitalized monitors does take care of the patient's adherence as well as pseudo-adherence and tail-off phenomena much better, leading to better asthma control. Second important study is, which is just 2 days ago, has published by our colleagues in PGI Chandigarh. Ashutosh Agarwal has reported this, that in Indian asthmatic patients, if you have to compare DPIs versus PMDIs, then those patients who are on meter dose inhalers, their asthma is better controlled. in comparison to those who are on dry powder inhalers. Perhaps this is an answer to tell us that why is this happening so and what to do when the patients are uncontrolled on dry powder inhalers. These are multiple comorbidities, we all know about them, but this is the time when the patient is uncontrolled, you need to revisit them. Obstructive sleep apnea, upper airway cough syndrome, GERD, smoking, COPD, psychological issues, hormonal influences, and so on and so forth. If they are there, they all need to be addressed before proceeding ahead with categorizing the severe asthmas. And then we reach to the step 4, step 5, and if you look at it here, step 5, GINA 2018, what it is telling us is there is an option of using 3 drugs here, omalizumab, then we have mepolizumab, and then we have a benralizumab. So we have a biologicals to treat this provided the phenotypic has been done. Before phenotyping, if something can be added to these patients is tiotropium and theophylline, which would be a difficult scenario for us because most of our patients of severe asthma which are therapy resistant would anyways be on theophylline and tiotropium. So management of severe uncontrolled asthma in 2018 will have add-on therapies like LAMA, which is tiotropium, theophylline, and of course now with the newer data coming up of azithromycin, which does not require phenotyping. But add-on treatments like oral corticosteroids is the last step in the low dose, which we are trying to avoid. So for that we have alternatives like biologicals, where we have anti-IgE, which is omalizumab. We have anti-IL-5, which is like 3 of them, mepolizumab, benralizumab, and racilizumab. And we have again anti-IL-4 and 13, which is dupilumab. We have also bronchial thermoplasty and immunotherapy options if the patients are candidates for that. So some of these therapies are already there and available in India to be used in 2018, and since DCGI already approved mepolizumab, we are expecting in a couple of months that we would be having our hands-on experience of using mepolizumab in the right set of patients of severe refractory asthma. As I said that without phenotyping, azithromycin has come into severe asthma, which is a little surprise because we thought azithromycin works in non-eosinophilic asthma according to the initial studies published in Thorax, which did show that the azithromycin decreases the number of exacerbations in non-eosinophilic severe asthma patients. But in 2017, the study, AMAZE study which came, it showed that yes, azithromycin works in severe asthma patients, and if you look at it, it does not matter at the baseline eosinophil level. So what it means is it shows that it works in both severe asthmas, whether their eosinophilic counts are high or eosinophilic counts are low. So in 2018, beyond this, we need to phenotype our patients, and phenotyping is required because asthma is heterogeneous disease. It presents with different symptoms, different triggers, and of course it's got a different response to current therapies which are available to us. Variation in presence and type of inflammation is the crux of what we are looking for endotyping asthma for the targeted therapies. And of course this is manifested as reduced response to inhaled corticosteroids in some of them. And we have also noticed that now some viral induced infections and bacterial infections are also responsible for worsening or a subtyping type of severe asthma. So what are these phenotypes and endotypes? Of course, most of us understand that phenotypes are the clinical characteristics by which we can just look at the person and say, this is the typical phenotype of the patient. It could be clinical, physiological, and many others. But endotypic is the one which is primarily trying to look into the pathobiology and the inflammation which is going on to the airways of the asthmatic patients. So we may have a clinical phenotype like corticosteroid dependent asthma, patients who have got asthma with frequent exacerbations, and patients who have got asthma with fixed airflow obstruction. But all of them could be endotypically into either allergic or non-allergic, which we call Th2 or non-Th2, or Th2 high or Th2 low inflammation in the airways. But the important aspect of this phenotyping and endotyping is that it is not a watertight compartment. It is a fluid in a state where there is a significant overlap and sometimes endotypes do change. So it's not a fixed kind of a criteria which could be there always, but in some of the patients it's in a state where they will change over a period of time. When we look into the inflammatory endotypes to address these issues, we look at the Th2 and non-Th2 inflammation, and we know Th2 inflammation is when allergens are handed over across the epithelium to the dendritic cells, which makes them to process through Th2 inflammation, releasing interleukin 4, which ultimately goes on to lead to inflammation which is IgE mediated through mast cells, or interleukins 5, 4, 13, which ultimately recruit eosinophils and cause eosinophilic inflammation in the airways. On the other hand, when we talk about non-Th2 inflammation, then it is the pollution, the viral infections and other things which are transported across the injured epithelium and is processed by non-Th2 cells, and it releases a different set of inflammation which is primarily ICLC2 inflammation and causes a non-eosinophilic, non-allergic or non-atopic inflammation in the airways. So obviously in the emerging phenotypes, we will have allergic and non-allergic. Allergic is IgE mediated, which is atopic, as well as IL-5 mediated, which is eosinophilic, and we also have IL-4 and IL-13 mediated, which is also eosinophilic. In the non-allergic variants, we have non-eosinophilic, which could be neutrophilic, paucigranulocytic, as well as a mixed cellularity in which neutrophils and eosinophils may be there. And then again, as I said, there is an overlap with eosinophils. But the question is, if we are going to endotype the inflammation, are there biomarkers available so that we can pinpoint that which patient is going to respond to which kind of therapy? These are expensive targeted therapy. You need to know which patient is going to respond to which kind of therapy. So the available biomarkers are blood eosinophil count, which is very easy to do, but we need most of the time sputum eosinophil count, which is mostly done in the research settings. Serum IgE level, which is in fact directly related to IgE mediated inflammation, is again easily available, and exhaled breath nitric oxide, which is again a surrogate of eosinophilic inflammation or allergic inflammation in the airways, is also being installed at most of the places in India by now. So the question comes that if we cannot do the sputum eosinophils, are the blood eosinophils a good surrogate markers to tell us about the airway inflammation? And the answer comes from this study, which shows that if the blood eosinophil count is less than 100 in the absolute terms, then you have almost 92% chances that this asthmatic patient's airway eosinophils are less than 1%. On the other hand, if the absolute eosinophil count is more than 400, then there is almost 95% chances that the sputum eosinophil count is going to be more than 3%. And we do understand that 3% of sputum eosinophil is the marker which has been used by both of the, or most of the clinical studies in which it was used to mark the airway inflammation due to eosinophilia to target anti-eosinophilic drugs. So we have biological options for that, which are primarily either attacking IgE, interleukin 5, interleukin 4 and 13, and of course if there are other options would be like looking at the airway smooth muscle by using bronchial thermoplasty. Since IgE mediated allergic asthma is the most common, it accounts for almost about 50 to 60% of patients. This is the one which we are most likely to see as an uncontrolled severe asthma in our clinical practice. And for this, what we have is omalizumab, which is a humanized monoclonal antibody, and it is humanized because 90% is a human part into it and 10% is the animal protein, which is the porcinoprotein. And that's the yellow portions which we are looking at the anti-IgE molecule, which is being shown here. It binds to that sites which are required for binding to the mast cells. So once IgE has got two anti-IgEs on both the sides, then there is no site free for IgE to go and combine with the mast cells. Ultimately what it leads to is that the mast cells expression of these receptors on IgE, which is Fc epsilon E3 is concerned, they ultimately undergo significant regression, almost about 95%, and that is why even if you withdraw omalizumab, the mast cells being devoid of IgE receptors will still have a beneficial response for variable periods of time. The evidence for omalizumab is immense, and if you look at it from 2001 to 2018, there have been number of studies, and at each and every point omalizumab has scored in severe asthmatic patients by improving their inflammation, decreasing exacerbations and hospitalizations, improving quality of life, lung functions, continuing to have uncontrolled asthma. ACT scores were more than 20, across the continents, whether it is Australia, Canada, or it is US or Europe. Allergic asthma, which is IgE mediated in children and adult one. This can be atopic or non-atopic and may or may not be associated with nasal polyposis. And when it is associated with nasal polyposis, it leads to differentiation, more maturation, activation, and mepolizumab and racilizumab. And the third one, which is benralizumab, it acts on the IL-5 receptors, which are into improvement in lung functions and quality of life of the patients, as well as reducing exacerbations. This meta-analysis published last year did show that there is lesser need for hospitalizations, exacerbations are not, and that is irrespective of other things, but it was the important thing that these were all patients who exhibited the baseline eosinophil count in the blood of more than 300. Reduction in OCS use has been also demonstrated in Cirrus trial by 2018. We will be looking for our patients of